Hi, thanks for joining this webinar. My name is Rebecca Payne and I'm a Portfolio GP. I've been working doing video consults for the last 3 years. This is the second of a series of 3 videos looking at how to get the most from video consultations. So the first thing to ask is, does this really need to be a video consult at all? Now, I've been working in the sector for 3 years. I love video consults. I'm really enthusiastic about them, but actually the most important question is, will this really add value compared to a telephone consultation? Because often it will take 2 to 3 minutes longer per call than a telephone call. It is more likely to save more time for the patient than for you, and many clinically useful parameters can't be visualized. So it is useful, but is it the right thing for that consultation with that patient, or would a phone call do? And it's important to be realistic about what you're going to see through the webcam. Very often rashes and other skin lesions are best off photographed and uploaded or emailed to give you the level of definition you need to make a diagnosis. It is really easy to waste a lot of time either at the patient end or the GP end if you're not familiar with it. So don't let that put you off, but think about what you're trying to achieve before you start the consultation, and certainly before you decide if this is the most relevant modality to see that patient in. So what are you trying to achieve? Because that will influence how you go about it. If it's just a quick check that the patient isn't infectious before seeing them at surgery, that needs a really different approach to replacing a normal consultation with a video one. Another thing that you might be trying to do is just provide an extra level of reassurance to an anxious patient, relative, or perhaps a care home staff member. And video is really useful for doing that. And the exam question is, at the end of the consult, do you have the information you need to manage that patient as safely as possible? And that as possible is a really important caveat, because given the pressure that's likely to ramp up on the NHS through this coronavirus outbreak, actually sometimes we just have to do the best we can in a difficult situation. But do you have the information you need in the circumstances you're practicing in to manage as safely as is possible? And if not, there are some other things you can do that we're going to come on to later. So don't just get on the bandwagon. Do a video consult because that's the most relevant thing. Don't just do it because it's politically the thing to do. You'll find telephone consultations for a lot of patients are quicker and bring you just the same amount. So when do and don't video consults help? Well, they're really good for kids. I'm sure you've all had the telephone encounter where it sounds like a child is really, really poorly, and you bring them into surgery and they're tearing up your waiting room. It is good for seeing the child who is running around, playing happily, looking well, as opposed to the one that looks half dead on the sofa. They're really good for assessing mental health, and they provide an extra level of reassurance, both to the patient but actually to you. Really, really useful for those patients. They're useful to get a quick sense of the patient, particularly in relation to BMI. So say you're assessing somebody with potential cellulitis who's emailed in a picture, actually understanding the BMI of the patient can be really helpful for managing risk appropriately, similar with potential diabetes and other problems. Particularly where you don't know the patient. And patients find them enormously reassuring over and above telephone calls. So sometimes just being able to provide that extra level of reassurance is therapeutic in and of itself. There's 3 things in particular I feel that you need to be quite careful with. Their skin, eyes and abdominal problems. With skin and eyes, seeing the details of rashes and of eye problems is quite tricky on a webcam. Everything I've used has not given me that level of definition. And as I've already mentioned, it may be better to get the patient to email in pictures in advance of either a telephone or a video consultation, rather than relying on the information that the video consult brings. The other issue is abdominal problems. Now, these are really hard to assess well remotely, and both for telephone consultations and for video consultations, I would have a much lower threshold for seeing these patients face to face than for many other problems. So just bear that in mind, be extra cautious with abdominal pain. Have you got all the information you need to assess that patient? And I'm going to be frank, in my opinion, they've got a little advantage over the phone for most other things. So having decided that this is the right modality to use, it's time to think about effective communication. And actually, this is something we do anyway. All the normal rules apply, but with a few extra points. So the first thing is introduce yourself. I'm Dr. Payne, I'm from the surgery. Nice to meet you today. And then open questions. So we'll talk a little bit more about starting the consultation in a moment, but I usually say, do you want to talk me through what's been happening? Because regardless if I've got a lot of information from a patient that's been through a digital triage, or if I know nothing at all, that question is very relevant. And then follow it up with more open questions. Tell me more. Anything else? A little bit of effort right at the start of the consultation in building rapport and listening to the patient will increase your chance of being able to complete this care episode at that one consult, rather than the patient feeling, oh, the doctor didn't really understand, I need to come in so they can assess me properly. Even more than we normally should, I think it's useful to summarise and check back with the patient, because although we do get some more non-verbal cues than you do on a telephone, it is still not the same as being face to face with a patient. Can I just check? So the pain is around your belly button. Can I check? Did you mean such and such? Summarise it, repeat it back to them and check. And it's also quite important to signpost where you're going throughout the consultation. So I'm afraid I need to ask you a little bit more about your general health now before we move on to what we're going to do. And often, even more than face to face, I find on a video consult, patients want the solutions in the first 90 seconds of the consult. And it's so important not to get drawn into their agenda of what they feel the solution is, but to continue to do all the things you do all the time and make sure that you have got the full story before being led down a route by the patient. Again, I think it's really, really important to check the patient's thoughts about what this might be, particularly at the moment when there's all sorts of weird and wonderful symptoms that we know full well are not coronavirus, but for patients who have even less information than us, they can worry. And it's really important to summarise the action plan. And we'll go through these steps in a bit more detail, but these are all part of effective communication that's absolutely vital in this context. One of the things, though, that is a bit different is that most of the time there is a bit of a lag compared to the telephone. I'm sure you've experienced this yourself when Skyping friends or relatives. It's not completely synchronous. And that means when you're going, oh my goodness, that sounds dreadful. All the verbal expressions of care and of empathy that we normally use, they can just come in a little bit out of sync for the patient and make it sound like we're not really listening or paying attention. So be super cautious about those, and it may be better to nod vigorously and show that you're listening in other ways, rather than by putting in those listening noises that can detract from the communication in this setting. And it's absolutely fine to look away from the camera and type. It gets a bit like weird and scary if somebody is talking to you like absolutely glued on you in real life, and it is just the same. With natural conversations, we look away and we look back, and it's fine to do that. The only thing I'd caution, though, is try and get a quiet keyboard, because really noisy ones can be a bit off-putting. So let's go back to starting the consultation and expand on some of those points I've just mentioned. Something that's really important is to know who you're talking to. And it's best practice to start any remote consultation with, Dr. Payne here, could I just confirm a few details? First of all, could I confirm your full name and date of birth, please? Or could you tell me your full name and date of birth? And another really key thing, especially for an acutely unwell patient that might need an ambulance, is knowing where the patient is. So making sure they are at the address you think they are. So my next question is always, and I've got such and such an address down for you. Can I check, is that where you are right now? Now, if it's not where they are and they're calling about something really minor, perhaps an issue that has no risk of deterioration while they're on the phone, you may not want to establish exactly where they are. But if there is any risk that that patient is going to either need an ambulance or deteriorating collapse on the phone or video, we're talking about videos, you must know where they are. The next thing about starting it is get as much information as you possibly can in advance. So you might use a digital triage tool, which gives you a list of all their answers, or the receptionist may have taken some further details, or the patient themselves may have typed in a brief explanation. This is really, really helpful, but I'd advocate against relying on this information, particularly when patients are giving yes/no answers. They can sometimes either misunderstand or feel, well, yes/no doesn't really apply, and just select one that may not be appropriate. So, for example, a lady with abdominal pain, are you pregnant? Well, she might not have a positive pregnancy test, but actually pregnancy might be a possibility, but it might not be a high possibility. And when was my last period anyway? You can see the sort of things that patients work through in their minds before sometimes seemingly randomly selecting one option. So it's useful, but personally, I wouldn't use it like a checklist. You said this, this, and the other. I would still do a normal consultation because I think it's safer. But actually, I also think it gets you more likely to complete the consultation without the patient feeling, I wasn't really listened to, and calling back. People want to tell their story, and by allowing them to tell their story, often you can close it off. They feel listened to, sorted, no further contacts. Remember to use open questions, remember to summarise, and remember to be nice. It's a stressful time for everybody, especially for those of us working in healthcare. And I think it's so important that we just remember to be kind. And it's not just that it's a good thing to do, but actually it will keep complaint rates down. It'll mean a consultation is likely to not result in another consultation to get someone else's opinion. But actually people are often very anxious and wound up. If you've been sitting there waiting for a phone call, if you have been sitting there trying to work out how this app works and wondering when the doctor's going to pop up, people are wound up often to start off with. So just bear that in mind and make extra allowances. It will benefit you just as much as them. So what important information do you need? Well, I want to say, first of all, don't get distracted by the tech. Sometimes, particularly when I started doing video consults, I'd get to the end of the consultation and think, oh, I've remembered not to say, I've done this, I've done the other, but I never actually asked them about red flags. Don't get distracted. You can do this. This is just another way of doing what you do every day. And calibrate the amounts of information you obtain according to the level of information you already hold. So if it's your own patient, you've got full notes access, the list of medication is there, the list of allergies, their past medical history is there. That's really different to a patient you might be consulting with, say, through Adastra, where you've just got a summary care record and you need to check things in a bit more detail. And again, that's different to, say, a patient who is accessing through another route, perhaps private online practice, perhaps elsewhere, where you have no information at all. And so remember to work through the presenting complaint, history of the presenting complaint, past medical history if you don't have it, drug history, allergies. Just calibrate it according to the information you have. And remember to ask the red flags. I feel like I'm teaching my granny to suck eggs because I know this is stuff you all do all the time, but it is easy to get distracted by new tech, and it's important you just practice to the same high standards you always do. And the next thing is ideas, concerns, expectations. I'm taking you back to your medical school days. I find these really, really important in the online setting because the verbal cues are more limited, and also a lot of patients, particularly as this epidemic progresses, perhaps will not understand just how much it's affecting the NHS. They often have fairly unrealistic expectations, and exploring those, getting them out on the table, will prevent both complaints later, but actually it will make the consultation shorter because by addressing them head on, they're not coming back to them time and time again. Now I'm going to do another video about physical examination of patients, so we can go into different things like shortness of breath, abdominal pain, sore throats, UTIs, things like that in a bit more detail. But in terms of the big picture, be aware of the limitations of the technology. And you might want to consider, if you don't have enough information, stopping and getting them to upload or email a photo, a blood pressure reading, a temperature, any additional information you need. Think about it and make a conscious decision. Can I progress without this, for example? Pill review. Can you do without their blood pressure? Make it a conscious decision, and if you really feel you need that information, stop it, get them to send you the information, and then reconnect with them. Now, the camera is really great for big picture stuff, seeing are people mobilising, how well does the child look, and getting a sense of somebody's BMI. But even when they zoom in on something like a joint or a rash, you're often unlikely to get the resolution you need to make a good assessment of anything other than function. So you can see how far they're able to bend their knee, but you're unlikely to be able to assess just how swollen it is, or just what a rash looks like. So bear in mind, still photos, create a mechanism to get hold of them. They're brilliant. And we're going to pick up this more in the examination video, but get the patient to do the examination. You don't need to do all the hard work. We've already talked about temperature, blood pressure readings. Actually, when it comes to other things, abdominal palpation, looking in their throats, yes, it's not going to be as good as if you do it yourself, but it can give you an idea. And I would develop a pattern for talking patients through how you're going to do it, but we'll talk about that a bit more in the next video, or this is all going to get a bit long. So risk scoring and decision-making tools. I find these really, really helpful in video consultation. I think because you can't assess the patient yourself, being able to do a validated questionnaire and come up with an answer, it gives that extra layer of reassurance to the patient primarily, but actually also to you. I'd signpost that you're going to do it. So with fever pain, I'd say, I know I've already asked you some of these questions, but I just want to take you through a standardized scoring system and then ask them. I store these on a tab or in my favourites, so they're easy to pull up when I need them. And the ones I use all the time are fever pain. Then I talk the patient through the PHE UTI guidance, and there is a new coronavirus breathlessness score. I think I've seen on one of the documents sent to me in the last few days. I think that will be quite useful as well. So they give reassurance to the patient and to you, and actually they often deflect arguments. So by saying, well, the questionnaire indicates you don't need antibiotics, it does take the onus off you. So I would really consider doing this even if you're not doing them routinely in your clinical practice. And then on to decision making. What do you think this is? I think is a really important question for video consults, even more so than in the face-to-face environment. Often the patients that choose to use this modality to consult with us are the quite techy ones that have already done several Google searches and may have very fixed views about what's going on. Agree on next steps and summarise. I think there's an extra need to repeat it compared to a face-to-face consult, and be really, really, really clear both about worsening advice, the next steps, and how to take them. I'm going to do your prescription. Well, I might be doing your prescription. You're sitting at home. I'm 20 miles away. Where am I going to get it from? When is it going to be ready? Make sure that it is really clear and broken down into the specific steps the patient needs to take. And I think in this modality, it is really important wherever you can to give the patient written instructions. Now, this may seem like extra work, but you need to write what you've told them in your notes anyway. So actually by writing it in patient-facing language, you can just preface it with, I told the patient the following, if you such and such, and make it really, really clear. So you'll need to think through how you can get that information to your patients. Does the way you're doing the video consults allow a text, you sort of message the patient, text through it? Will you be sending emails? Will you be sending texts? Will you be sending WhatsApps? What you use is less important than the fact the patient is getting written information and a patient information leaflet. So I've got a tab for patient.info. I just open that up, find the relevant one and pop on the link as an attachment. Not as an attachment, just like paste it in. So the way I do it is right click on the, go to the leaflet, right click on it, and then you can copy that link and paste it in to share with the patient. But just make sure they're really, really clear, because this is as big a change for our patients as it is for us, and it's important they know what to do. And then what about referrals? Because actually a lot of us have been quite worried about referring somebody without having assessed them face to face. Particularly psychiatrists have been very reluctant to accept people who haven't had that face to face assessment, even where it doesn't seem to add very much. But in the current context, I think you need to think, do you really need to examine them to refer them onwards? And I would suggest if somebody's got a red flag that you're going to be referring no matter what you find, I think you should just do it. I don't think they should be called in to be seen face to face just so you can write a referral letter. Now that's my opinion. I think you need to talk to local authorities, your health board, your CCG, your LMC, and get that formalised. But it is very much worth thinking about. We need to change normal practice in current circumstances, and this is an area where we can. I'm going to talk more about prescribing on another video, and then about the next steps. So as you come to the end of the consultation, the key question you need to answer is, do you have enough information to treat that patient safely now you've gone through the video consult? If you don't, what do you need to do about it? Do you need them to email you a close-up picture? Do you need them to do OBS? If so, have they got the stuff? How's that going to work? Do you need to see them face to face? That's a few of the options open to you, but you just need to be sure in your own mind that you have got enough information there to treat the patient safely within the constraints that exist at present. And like I said, being really, really clear about the next steps for the patient. If they're being seen face to face, where, when, what are the arrangements? If they've got a script to collect, from where, what timescale will it be ready? How is it going to work? If you want to see them again, what are those follow-up arrangements? And again, I can't emphasize enough the importance of written advice and the patient information leaflet. That's quite enough for now. So just to recap, does it need to be a video, or will phone do? You can do this. This is what we all do every day. It's just doing it slightly differently. Make sure you get the information you need, and you might need to use other things like a photo to get that, not just a video. Use risk scores and other tools. I will talk about physical assessment and prescribing in another video. And finally, and I can't say this enough, make sure you're clear about the next steps and give patients written information. So thanks for listening, and hopefully see you on the next video.